Welcome to this evening's COVID-19 series. Topic 1 webinar is PPE and other non-pharmaceutical strategies. This webinar provides healthcare professionals the opportunity to have their questions answered by a field of experts in the field. And this program tonight, thankfully, is hosted by Prax Hub and is presented by the Immunisation Coalition. It's intended for health professionals. I'd like to acknowledge the traditional custodians of the various lands on which we work today and the Aboriginal and Torres Strait Islander people participating in this webinar meeting. I pay my respects to elders past, present and emerging, and recognise and celebrate the diversity of Aboriginal peoples and their ongoing cultures and connections to the lands and waters of Australia. My name is Angela Newbound and I'm your facilitator tonight. I'm an immunisation education consultant based here in South Australia and a member of the Immunisation Coalition. I've provided clinical advice, support and education to immunisation providers across South Australia for over 20 years and provide clinical guidance to the Immunisation Coalition with the development and updating of the Numa Smart vaccination tool. Presenting tonight's meeting is Professor Mary Louise McLaws and Dr. Susan Jane. Mary Louise is a member of the World Health Organization Health Emergencies Program Experts Advisory Panel for Infection Prevention and Control Preparedness, Readiness and Response to COVID-19. For several years, she was a short mission World Health Organization advisor to China and Malaysia for surveillance development. She collaborated with Beijing to review the response to the severe acute respiratory syndrome or SARS outbreak and healthcare worker safety for the Hong Kong SARS designated hospital. Mary Louise provided advice for 9 years to the WHO Clean Care is Safe for Care Challenge program. She is commissioned by the Commonwealth to review the pandemic influenza infection control guidelines for evidence of protection for healthcare workers. Susan has a PhD in transmission-based precautions from the University of New South Wales and just completed the Master of International Public Health with UniSA New South Wales and a Master of Nursing from University of Wollongong. She is the Senior Clinical Advisor and COVID-19 Response Lead of the Healthcare Associated Infection HAI program at the Clinical Excellence Commission in New South Wales. She carries over 30 years of professional clinical experience, principally in infection prevention and control, intensive care nursing and the operating theatre. Her work in infection prevention and control includes both supporting and advocating for health worker and patient safety, primarily in reducing the risk of COVID-19 transmission, prevention of hospital-acquired infections, and management of multi-drug resistant organisms in healthcare settings. Mary Louise and Susan have known each other since 2013 through their professional linkage, and more importantly, Professor Mary Louise and Susan's primary supervisor for her doctorate, and they have published a number of peer-reviewed research papers together. They jointly teach medical students and Master of Public Health students at the University of New South Wales. Their working relationships extend beyond the academic arena by representing a number of state and national committees together and enjoying Susan's husband's superb cooking together. Thank you very much for that, and welcome to Mary Louise.
Thank you very much, Angela. So let me take you through the first of all, the first poll I'm going to give you. And the question is, what's the longest duration that influenza A can survive as a fomite? That is, as a contaminant on a contaminated surface. Is it 0 to 6 hours, 4 to 9 hours, 1 to 3 days, or more than 4 days? Well, it really depends on the papers that you're reading and the lab methodology. So some of the lab methodology and papers will say that influenza can last for up to 4 or more days. So let's have a look at the evidence for fomites. So in 1982, Influenza A virus was found to remain infectious for up to 2 days on hard plastics and stainless steel. Then in 2006, H1N1 influenza could persist for up to 6 days on non-porous surfaces, longer than on non-porous surfaces and porous surfaces. And then 2 years later, influenza A was found to be infectious up to 3 days on Swiss banknotes. That was done by Didier Pittet, the rock star of hand hygiene. And in 2011, 2 strains of influenza A were found to remain infectious at varying periods of time on varying surfaces. So let's have a look to see what they found. So this was a lab test where they looked at a single determinant of genomic survival, and then they also they did 2 to 3 replications to find out whether or not they were viable. So there's one thing to find it, there's another to see whether it's viable. As we can see here, this dotted line here is plastic with a little 0 sign here. And then here is cloth, etc. The square is pine, and they all have varying genomic survival. But how infectious are they? Well, the mean was very short indeed. So mostly stainless steel and plastics found that the survival remained longer on those 2 surfaces, which is fascinating considering that we put both of those materials throughout hospitals. So on high touch household surfaces, they found that live virus survived for 4 to 9 hours on light switches, which are made of polyvinyl chloride, computer keys, up to 4 hours on wood surfaces and stainless steel. And yet others have found that it's up to 4 days. And of course, undetectable after a whole day. So what can we take from that? Well, it's very complex because it really depends on the quality of the test. And don't forget, most of these are done in perfect laboratory conditions. We have seen that copper has been the go-to new surface for potentially putting on the top of coating on plastic masks as potentially being able to filter out COVID and other viruses. I'm not sure how well that will be because copper is expensive and whether or not it can survive for, I don't know, a day or a week. It might be very expensive. They're talking about it remaining viable for longer than the current masks, but we'll see. QUT has made a nanostructured aluminium surface that inactivates COVID-2, i.e. The COVID-19 disease for really rapidly within 6 hours compared to the normal 48 or 2 days on smooth surfaces. So that's a good news. However, it still tells you that COVID can last for quite some time on surfaces and hand hygiene and cleaning in houses where we've got patients or cleaning between patients in GP offices is really important. So I myself, as the supervisor, along with the lovely Professor Bill Rawlinson as the other supervisor of Jan Gralton's PhD, looked at whether or not it was true that viral infections are only expelled as a certain size particle, because there was this hypothesis that there's a cut point that influenza is only spread by aerosolized particles, in other words, less than 5 microns. and other viruses are spread by only droplet or droplet nuclei, the larger ones. Now, is that true? So we looked at 12 adult and 41 pediatric patients, Jan and Yuvan Tovey. I cleverly adapted what's called an Anderson sampler, so that when patients coughed or breathed through the sampler, we were able to recover RNA and identify whether or not the viruses, what size they were and which ones we had, and how small the particles were. So we identified influenza A and B, parainfluenzas, respiratory syncytial virus, human metapneumovirus, and human rhinovirus. And so do you think that we found influenza as only the small sized droplet nuclei? So what do you think? Do you only exhale droplet sized particles or aerosol sized particles? So remember, the theory is that influenza is only spread by very small particles equal to or less than 5 microns. Or do we expel both size particles with influenza A? Well, clever you, 93% says both. Okay, so in fact, that's right. But before we did this, there was this hypothesis that it's only ever exhaled in small particles, and therefore you had to wear an N95 mask because that's how it was spread. Jan wrote a beautiful piece on the problem of sizing particles as well. And it still is problematic unless you have an electron microscope. So here are the results just scattered around, looking at the different size particles from stage 6, which are the smallest, all the way through to the largest. And we found that participants produced particles containing RNA of all of those respiratory infections through breathing, tidal breathing. 58% produced greater than 5 micron particles. 80% of participants produced small particles as well. On coughing, just over half produced large particles, and of course, 82% produced small particles. So, I mean, rhinovirus wasn't ever thought of as spreading by both types of particles, and certainly flu was only thought to be spread by small particles. So the conclusion that we drew was that symptomatic respiratory viral infections produce both large and small particles carrying viral DNA in coughing and breathing. Now, we still do use the idea of the cut point of small particle sizes to decide whether or not we're going to use a medical mask, i.e. a surgical grade mask, or N95, and Susan will take you through that. But the history of how we decided to wear what mask is fascinating. And I think I've got just a moment to quickly tell you what that history is. So in the late 80s, about 10 healthcare workers in America acquired multiple resistant TB. Now, in those days, you had to put your mask on about 1 meter away from patients. And we know now that that's far too close. But also, all of these 10 clusters of healthcare workers acquired multiple resistant TB, which is a deadly diagnosis. The then famous epidemiologist from Houston, Texas, wrote a piece saying there was nothing else to suggest that healthcare workers should wear. So he couldn't continue to suggest they wore medical masks. So they decided that they should wear respirator masks. We call them P2 or N95s. But later on, it turned out that a lot of those 10 healthcare workers had an immune issue such as HIV. And of course, we now know that we don't don a mask before we don't don a mask and while we go into the room. We don a mask before we enter the room. So there were 2 issues going on there, but nevertheless, it's now part of history, and we decide on a cut point of particle sizes. So influenza A and H1N1 are exhaled in both a droplet and airborne sized particles. Indoor domestic surfaces at temporal level, at temporal temperature and humidity survive for a few hours and rarely up to 9 hours. Metallic and non-metallic, non-porous surfaces are the greatest risk and need greatest targeted for frequent cleaning, especially those surfaces that come into close proximity with patients. So in your patients' waiting rooms or in hospitals, high-touch surfaces need to be cleansed regularly. In hospitals, it's usually twice during a shift. But in fact, in a GP practice with so many patients coming in, you might decide during flu season that you might want to clean more often. The findings support the frequency of cleaning high touch areas, as I mentioned, particularly when you've got symptomatic patients. So now let's talk about, on the one side, SARS-CoV-1, and on the other, on the very bright, pretty color, SARS-CoV-2, and what we know about that. So can you tell me how are the modes of transmission for SARS-CoV-2? Is it mostly fomite, mostly droplet spread, fomite and droplet, mostly airborne spread, mostly airborne and droplet, or is it droplet, fomite, and airborne spread in the right conditions? Droplet, fomites, absolutely, but also in the right condition, airborne spread. WHO has written these guidelines, and I was fortunate to be on the working party, and we sieved through all of the evidence, and of course the evidence had some really well constructed science. Some were lab-based, and some of course had lower level scientific design, and concluded that respiratory secretions or droplet expelled by infected individuals can contaminate surfaces and objects, creating fomites. Viable COVID-2 viruses and RNA can be found on those surfaces for periods of time ranging between hours and days, depending on the ambient environment and on the type of surfaces, in particular at high concentration in healthcare facilities where COVID patients are being treated. So if we have a look at the current evidence between these two these two viruses, SARS-CoV-1 and SARS-CoV-2, what have we found? So aerosols, SARS-CoV-1 and 2 were both found to survive in lab-based work for 8 to 4 hours. Cardboard, up to 24 hours with SARS-CoV-2, but let me remind you that when you get your takeaway dinner, don't panic about SARS-CoV-2 because it's unlikely that it survived outside this perfect laboratory condition. Stainless steel, definitely for a couple of days, and plastics for 3 days. So what about droplet and airborne spread? So WHO, as you probably are aware, received some complaints from scientists, mainly physicists and engineers, and some respiratory physicians, saying that we were not giving airborne spread enough of a consideration for the infection control. And in fact, we had actually put in that airborne spread was possible, but we didn't say it was commonplace because the epidemiology suggests something that's not commonplace. But having said that, certainly some of the outbreaks in healthcare workers you would have to consider in line of the airflow change. We do know that WHO requires airflow change to occur in the wards and preferably in newly built environments to be up to 80 litres per second per patient. And we know that most of the older hospitals can't meet that. They may be 40 to 60, or sometimes even less. And certainly when airflow change is low, small droplet nuclei can hang in the air for longer. So this was a very nice lab-based study done looking at if somebody coughed and there was no wind, how fast this plume of droplet and aerosols hung in the air and how far they went. So as we can see, they don't travel that much distance when there's no wind or air flow. So at 0 kilometers per hour, this plume will hang in the air. It'll have dropped about 0.6 of a meter and will hang in the air for about 1 second and drop at it very quickly at less than 1 meter. And of course, it eventually dissipates. However, as soon as you add some airflow to this, the smaller particles are lifted and pushed further. Now, we do tell people that you're at less risk when you're outdoors because you've not only got the air flow dissipating, but you've also got the desiccation through lack of humidity, for example, or the sun. So you are at less risk even though it doesn't look as if you are. The aerosolized particles are about 1,000th of the size of a droplet. So you need a faceful of droplet nuclei to get infected, and certainly that can happen, particularly indoors with very poor airflow. I think it's a real risk, but hopefully in most healthcare settings, you've got better airflow than in the average, say, gymnasium or office block, which has a very poor airflow change of possibly less than 4 litres per second. So WHO says that a susceptible person could inhale aerosols and become infected if aerosols contain the virus in sufficient quantity. However, we don't know what that quantity is yet, and nor do we know the proportion of exhaled droplet nuclei or respiratory droplets that evaporate to generate aerosols and what that infectious dose is. Another recent experimental model found that healthy individuals can produce aerosols through coughing and talking, and another model suggested high variability between individuals in terms of particle emission. And particularly this can happen during vocalization. And one of our researchers at the University of New South Wales, a group of them have done a very nice video looking at somebody singing. So outside the medical facilities, some outbreaks reported have suggested that the indoor crowded space are possible aerosol transmission, and that is true. However, these are short-range aerosol transmissions and in crowded conditions with inadequate ventilation. And some of these outbreaks have occurred, for example, the bus outbreak with less than 3 litres per second per passenger. So it's no wonder that these aerosolized droplet nuclei hang in the air. So we still believe that certainly this is absolutely possible inside crowded and inadequate ventilation. So in conclusion, exhalation produces both small and large particles, mostly droplet and fomite spread though, because our epidemiology would be different. But we certainly look towards the Victorian number of healthcare workers. I think there are over 2,500 of them who have been infected occupationally. Were they all working on a COVID ward or how have they become infected? Could it possibly been aerosolized particles? So that is of great scientific interest to us. Infectious dose remains unknown, and airflow is important for opportunistic airborne spread. Finally, evidence suggests that SARS-CoV-2 RNA can be detected in people 1 to 3 days before their symptoms, onset of symptoms, with a high viral load observed around the day before or around the day of the symptoms, followed by a gradual decline over time. The duration of positivity appears to be 1 to 2 weeks for asymptomatic people, and up to 3 weeks or more for patients with mild and moderate disease. I was part of a meta-analysis team led by Professor Paul Glasio, and we found that asymptomatics represent about 20% of patients, not up to 50 or even 40. That was based on the Princess Diamond experience, but they didn't follow up the patients to see whether or not they eventually develop symptoms 7 to 21 days later. And so up to 20% we believe, and also we believe that asymptomatic people are about 44% less likely to spread infections compared to patients with symptoms. So in conclusion, SARS-CoV-2 and SARS-CoV-1 are similar for stability under experimental conditions, but they do have different epidemiology. SARS-CoV-2 have asymptomatic cases, and also the problem of the serial interval with SARS-CoV-2 is very different from SARS-CoV-1, which probably explains why SARS-CoV-1 disappeared so rapidly. With SARS-CoV-2, you become infectious on about the 3rd, 4th, or 5th day post-exposure, and that's problematic because you haven't developed symptoms yet. SARS-CoV-2 is transmitted mostly by droplet and fomites, but there is evidence of aerosol spread in the right circumstances, and SARS-CoV-2 can be occupationally acquired for healthcare workers.
Thank you so much, Mary Louise. That was really, really interesting. But we do have one question already, Mary Louise, for you. Anne would like some definition on what is a fomite.
Okay. A fomite is considered a contaminated surface with the virus still alive, so that you can contaminate a hard surface or cardboard, as we've seen in the evidence, but whether or not you can get the infection is another thing. So the virus will fall on the hard surface, and if it's still alive in large enough numbers, then you can become infectious. So we say that SARS-CoV-2 can be spread by contaminated hard surfaces, i.e. a fomite spread, but in truth, we don't know how important that is. So of course, we desperately want people to clean the environment in healthcare settings, but we also believe that a lot of the spread is mostly by droplet, then fomite, and then opportunistically airborne spread.
We've got another question, and it was just on your last slide, Mary Louise, in regards to Redora's asked, what do you mean by serial interval of 3 to 5 days?
Yes, thank you. Sorry, that's an epidemiological term that I should have explained. We use the term serial interval to mean what's the interval after being exposed where you can become the source of infection before you start to become symptomatic. So it's called the serial interval, and it's day 3 to 5. In other words, if you're exposed to SARS-CoV-2 on day 0, then 3 days later, you can become infectious to others before you even know you're sick. you don't have any symptoms. And then it can continue on day 4 and day 5. And then you then often by that stage start to develop symptoms on day 5 or 6. And then you're more infectious than when you were asymptomatic, but still infectious during that serial interval.
Thank you very much. I think we might try and sneak in one more question. Just in regards to airflow, realistically, would it be worthwhile considering a fan in a GP waiting room as well as the air conditioning, or would this make it worse?
So there hasn't been a lot of studies done on the air conditioning plus a fan, but my question would be, is the air conditioning using fresh air coming from outside? And if it is, then that's a good thing, because a lot of air conditioning just uses recycled air because it's cheaper. But if you're using fresh air coming from outside, you need to find out from the air conditioning people, or maybe an air conditioning engineer, exactly how many times, in the old terminology, it's called air change per hour, ACH. In the new term, it's called liters per second per patient or per person in a room that's 2 by 4 by 3 cubic meters. And then they'll tell you whether or not you're at least 40 liters per second per person that you think is going to be in your waiting room. Adding a fan may accidentally push the very small droplet nuclei even further to get a faceful if you're downstream from somebody breathing it out or speaking. And that's why I often say, when you're in a waiting room or when you're in a queue, don't speak, because the more you speak, the more you're producing aerosols and droplets, and you don't want that. And certainly, sadly, in your waiting room, you might have to ask your patients, unless of course they're parents, try to keep that speaking down, because if you're in the serial interval and you're chatting, that will push it out. Plus, if your air conditioning isn't very good. I'd also ask that they open up the window and the doors and refresh the room for at least 45 minutes to an hour after, each group of patients coming through, say at lunchtime and then in the afternoon.
Just another one in regards to air movement. Does air movement from patient warming devices or hover mats increase the risk of spreading aerosols?
I haven't thought of that question.
Oh yes, they're a good audience.
How lovely. Gee whiz. Look, it's unlikely. We don't ever say impossible. We often,
Sure.
give unlikely. I don't believe that would be considered an aerosolized generating procedure. So I wouldn't worry too much about that. What do you think, Susan?
I agree, Emma. It's not an AGP because the source is not actually producing anything. But if we have particles suspended in the air, and if this instrument, whatever it is, creating that air circulation is mostly a positive flow, the chance of us exposing is unlikely, because if we know that the patient has COVID, then you probably will have at least a surgical mask, or if it is any other respirator. So your chance of getting contaminated or picking up the microorganisms unlikely. I would suggest the low risk, but as Emma said, you can't completely ignore or say that it's zero risk. Okay, so risk management in healthcare. So as we know, risk management in healthcare comprises the clinical and administrative processes, systems, and reports employed to monitor, assess, mitigate, and prevent risks. So deployment of healthcare risk management has traditionally been focused on mainly patient safety and healthcare worker protection. So this is the hierarchy of control, developed by NOSHA, the US, occupational health and safety workers. And in here, elimination of a hazard is the most effective way of controlling. But in healthcare, as you know, our hazard will be a patient, which we can't eliminate. And then substitution, again, replacing the hazard. In hospital or healthcare, it's not possible. Engineering, we can definitely try. And then comes the administrative, and the least effective is the PPE. Some of my audience will be surprised with that, but that's the fact. So I'll take you through a bit more in detail how we think so. So elimination is kind of a social isolation. So we can't completely remove the patient, but we definitely put some restrictions around the patient or the place where the patient is, like public health restrictions, not to go out when you are sick, testing availability so that we can, reduce the hazard by knowing who is at risk. Contact tracing, also another kind of an elimination where you can find out who might be the contact and then isolate them. Work from home policies, which I'm doing currently as we speak. Telehealth consultations, like in GP practices, rather than everyone rocking up to a GP practice, we can implement telehealth. Visitors restrictions, ask people not to visit, or if they're sick, definitely not to come to healthcare facilities. Early discharge of patients, no recurring inpatient care, and then use of remote meeting technology or virtual visit. So those kind of elimination policies or measures can control some of these issues. And then look at substitution. So if we have an immunization or vaccination available, that will be one of the way to substitute the risk. But with COVID, unfortunately, at this point in time, we don't have anything as such available, but fingers crossed by next year, probably will, but we can't guarantee the timing or when that would be. Look at engineering, as Mary Lou's presentation definitely talked about the airflow, air circulation. So we can definitely look at our ventilation in the settings or healthcare settings or GP practices, clinical or non-clinical, and look at the availability of negative pressure rooms. And if we can accommodate non-COVID positive patients in negative pressure rooms, that's a really good idea of managing or reducing the hazard. Physical separation of patient groups, like single rooms. If you can't find a negative pressure, at least a single room with door closed. Adequate space for healthcare workers, like in tea rooms, not to cram everyone into one small tiny rooms or in meeting rooms. Provision of break rooms with enough spacing, and also enough physical barrier for public facing healthcare workers, appropriate equipment and cleaning regimes. All these engineering controls can be implemented to reduce the risk. And then administrative process, like having appropriate policy, procedures, guidance and recommendations for healthcare workers to use. Appropriate governance is really important. National and state guidelines, regular communication to healthcare workers and also to public. Workflow changes to enable physical distancing, like as I said in the tea rooms, for example, or spacing the chairs or the tables in restaurants. Bed allocation, have specific COVID ward. Healthcare worker training and monitoring of PPE compliance. Hand hygiene, definitely. You will be hearing hand hygiene word in every second of my slide. That important that is. And then cleaning of shared equipment and the environment. This kind of administrative process can also implement it to reduce the risk. Then comes the least protective equipment, which is the PPE. So what is PPE? PPE is the clothing or equipment designed to be worn by someone or healthcare worker to protect them from the risk of injury or illness. PPE has been evolved over the centuries, and we were using PPE since a number of years, as we all know, and it is becoming more and more complex and challenging, especially when you look at some of the respiratory protective equipment. It look like we're going to go to moon or into space. That complex sometimes some of them looks like. Okay, so where does the use of PPE fit into the risk management process? So as I mentioned already that use of PPE is the lowest on the list of control priorities. What we need to do, we need to implement all the other hierarchies of control, like elimination, substitution, engineering, and administrative control. And then along with it, I'm not saying that we don't need PPE, we definitely need, but PPE alone will not do the job. We need to have all the other measures put in place, and then PPE will be an added incentive to protect us. So it's the last resort where there are no other practical control measures available. So who should wear PPE? Healthcare workers definitely, GPs, patients, visitors to health facility, and also public or in the community. So commonly used PPE, I'm sure every one of us or people who are listening to me, you probably heard a lot about PPE this year. This, 2020 is a year of PPE, I would say. So there are gown or apron, eye protection, respiratory protection, and gloves. That's the main PPE we use in healthcare. Gloves, I can't talk to you enough about gloves. It's good to protect us, but we can't eliminate hand hygiene. So what's happening at the moment, or historically, that when you put a synthetic layer, the gloves, the role of hand hygiene just diminishes, or we don't feel the urge to clean our hands when you put on a synthetic layer. So that can cause cross-contamination. So when you put on gloves, you must perform hand hygiene before putting on to avoid contamination of outer surface of the gloves. And after removing, we must clean our hands to avoid transfer of microorganisms to another person from our skin or patient's environment or to clinical equipment or to other healthcare workers. So it's really important for us to stick with hand hygiene regardless of you wear gloves or not. Then comes apron and gown. You can choose either depending upon the risk of care you're going to provide. So mostly in healthcare, we use disposable aprons or gowns, and fluid resistant, it must be recommended for general clinical use when close contact with the patient or a material or equipment to prevent the contamination of the uniform or the clothing you're wearing. So again, it's important for us to use it properly. And selection of the apron versus gown will depend upon what kind of care you're going to provide to a resident or a patient. If you are interested in knowing a bit more about appropriate use of PPE, Emil and I published a number of articles in peer-reviewed journals. I have left the link here. I'm sure these slides will be shared after the presentation. I'm happy for you to go and have a look at those papers. And also, we put together a video, YouTube video to show the challenging the dogma of glove use for conduct precautions in Australian hospitals. It's a great resource for healthcare workers to go and have a look. So then comes the eye protection. We wear eye protection to protect our conjunctiva from splash or spraying by blood or body fluids. And it comes in various size shapes, safety glasses, mask visors, goggles, or face shield. And it is recommended for close contact within 1.5 meters of a COVID-19 patient, or it's part of the standard precautions too. Eye protection is nothing new to healthcare workers. We have always used and we are aware of eye protection, but I don't know, the utilization wasn't that great before COVID. That's my understanding. But prescription glasses aren't the protective apparel. So if you wear prescription glasses, you must use one of these on top of it to protect your eyes from getting splashed or sprayed. Then comes mask. I don't think I need to talk a lot about surgical mask, because we have seen mask in various sizes, shapes, form, interesting prints. So it's loose fitting and must be fluid resistant if it is surgical, and disposable. We use it to prevent large bodily fluid droplets that contaminates our nose and mouth. It protects us from splash or sprays or coughing or sneezing of people. And animal models suggest that aerosol SARS-CoV-2 transmission can be protected by source control by wearing a mask if someone is infected. or the people who are non-infected, they can wear it to protect themselves. So this beautiful graphs showing that, if you are infected, if you wear mask, you as a source, you will protect others from not picking up the infection. Or if you don't have infection, or you are an uninfected person, if you wear a mask, at least you will protect you from not picking up the infection from the other person who is infected. So general guidance over cloth mask. So it's normally 3-layer mask is the best, but if you can find something 2 layers will be good too. But fluid repellent or resistant would be the ideal, and it must be the outside layer, not the inside layer. Try to have one each time for the day. If you're going to wear the mask for the whole day, wash your collection of masks at the end of the day so that you're not going to be wearing the same cloth mask for the whole day. Handle the mask with clean hands. Treat your mask like a handkerchief, not to put on your desk or hanging around your neck. Clean hands before and after putting on mask and after adjusting it. Mask not for babies and the children under 2. It's a choking hazard for them. So, and also we don't generally recommend it for under 12 years of old. But if the parents can supervise, then, but definitely not for under 2. So how to don a mask? Why I put this slide, though, I have seen varying approaches or way people put mask on, mostly inside out. The problem, though, because I just mentioned previously that the outside layer should be fluid repellent, so that if someone cough or sneezes or some splash or spray hits onto your mask, the outside should be able to protect that droplet or wetness from that splash or the cough. If it is not fluid resistant, you're not going to get that protection. So make sure that you determine the outside of the mask. Mostly it comes with a bright blue facing and white inside, but because it can vary from manufacturer to manufacturer, you may need to check the box clearly to see how you will look at the inside or outside of the mask. And then you will have a bendable edge on the top, which should fit on top of your nose, and you can mold it to pinch the shape to the nose bridge so that it's not going to drop. Mask with ties. Take the bottom tie in one each in hands and then secure. Or if it is loops, you can just hook them, behind your ears. Pull bottom mask over the mouth and chin. So I'm sure all of us have seen people putting the mask under the nose, just sitting over the lips. That's not going to protect your nose because we have mucous membrane inside our nose and also in our mouth. The purpose of wearing mask is to protect both mucous membranes, so must be sitting above your nose and under the chin so that you will get that whole cover. So mask etiquette, that's what I just developed this term very recently. You will see all these different style of mask wearing. The first on my left hand side is the do's. So it must cover your nose and mouth, as I said, pull hair back. So having hair down and all of your face will tend you to touch your face often. Tie straps behind head or neck if it is a tied one, or if it is ear loops, you must put the loops behind your ears. Remove by only grabbing the tie or the loop, not by touching the front of the mask. So it shouldn't be hanging on one ear, or definitely not on your forehead and not on your neck or under the chin. So there are a number of ways people tend to put the mask on, especially when they talk or eat. And from Emma's discussion, we have learned that by talking or singing, we can expose a number of aerosols or droplet nuclei. So having the mask under the chin is going to defeat the purpose of wearing one, and also contaminate your own face, cross-contamination. So when you wear a mask, change when moist, regardless of it's surgical or cloth. Change when sprayed or splashed, your mask accidentally, or if you're changing the mask. Removing mask, always perform hand hygiene before you even go close to your face, because we have mucous membrane in our eyes, in your nose, in your mouth. So always have a clean hands before you approach to your face. And also by using a lot of PPE, especially mask, we have seen pressure injuries on your face, especially nose bridge or on your cheeks. So if you develop issues like hand and skin sensitivity problem by using alcohol hand rub, you must report your manager or your supervisor and address the issue. Not to leave it or not to wear mask. That's not the choice. You have to protect yourself by wearing PPE. So escalate it so that we can get some kind of an action to protect you. And also follow local reporting process and work health and safety process if you have such things already implemented in your facility where you work. So respiratory protective equipment, mostly a respirator worn on your face, covers at least nose and mouth, used to reduce various risk of inhaling hazardous airborne particles. So that goes back to our question of when should we use it. So when there is an airborne particle transmission risk, including dust particles or infectious agents. For industries, they will look at the dust or smoke or infectious other agents like gases. But in healthcare, we look at the infectious agents or microorganisms. Respiratory and facial protection required when droplet or airborne transmitted pathogens we deal with. Airborne particles have been artificially generated. For example, respiratory aerosol generating procedures. We definitely need to wear a respirator. So there are a number of respirators available, and they've been classified and defined into different groups. So the first one is air purifying respirator. That means the filter will purify the air when we inhale. And also the other group is supplied air, so air will be supplied. So we don't use supplied air respirators in healthcare. It will be mostly used in industries or scuba diving or any of such places. So where you've probably seen the canister hanging on the back of the wearer, and the air will be supplied. But in hospitals, we mainly use air purifying. So it can again divide into particulate or gas filtering mask, and it can be powered or non-powered. So if it is powered, mostly it's a full face, but you will also find powered, half face. And non-powered one, also called elastomerics, or disposable ones are N95 or P2. And then, powered ones comes in loose fitting or tight fitting powered air purifying respirator. So let's look at the non-powered respirators. So they draw air through the filter by inhalation. As I said, there are several types. Mostly in healthcare, we use disposable filtering half face piece, which is the P2 or N95. So in Australia, we call them P2, and in USA, they call them N95. It's same thing, but when it comes to the testing of these respirators, there's a slight difference. That's why N95s look for 95% filtration and P2 look for a 94% filtration. But do the same job. And reusable, usually termed as elastomeric, reusable half face pieces. And also half face is one or more replaceable filters, and full face comes with a head covering or a hood or with a hard plastic cover. P2 and 95 respirator essentially a same type as half face ones, intended to protect the wearer from the airborne contaminants. Form a seal over the mouth and the nose for efficient filtration from airborne particles, and it must be fitted and adjusted to correctly fit to your face to get the provide the intended protection. So in order to get the optimal use of P2 or N95 respirator, use correctly fitted P2 and N95. It's very important to do fit check. I can't tell you enough how the importance of doing fit check at the point of use every time you don a respirator, regardless of you had a fit testing or not. So when should you use it? When you're attending patients with probable or suspected or confirmed respiratory infections or communicable diseases with potential for airborne transmission. For example, pulmonary or laryngeal tuberculosis. And also when performing aerosol generating procedure on patients suspected or probable or confirmed COVID-19. And also any other respiratory infections where, it will be, if the patient going to have an AGP. And also by maintenance staff potentially exposed to inhalation of dangerous particulates or gases. And also the guidance is evolving from international and national experience and evidence. We also recommend use of P2N95 respirator for suspected or confirmed COVID-19 patients when they are cohorted. Also, if you are going to provide care, frequent care, and for a long period of time in COVID-19 dedicated wards, or people confirmed of having COVID-19 and has this aerosol generating behavior, for example, screaming, shouting, and spitting. Us going back to Emma's discussion around the right condition. So if you are in a place where you think that the room is very small and the patient, the number of patients cohorted is high, those kind of times, I think it's a good idea to use a respirator to protect you from that cloud of droplet nuclei. So as I mentioned, fit checking or user seal check is really important. When you wear a respirator, you must do this check. Otherwise, it defeats the purpose. So the purpose of doing that fit check is to get that seal to your face and the respirator. So respirator sealed over the bridge of the nose and the mouth, and there shouldn't be any gap between the respirator and the face. So the problems with facial hair, you probably heard a lot during this last 10 months. So if you have 1 day stubble, as the manufacturer of the respirator says that you will not be able to achieve a good seal, or if you have massive scarring or anything which comes in between your face and the respirator will interfere with the seal. So we need to make sure that you check all that before you put a respirator on, and do the check to see if it is rightly sealed, and then proceed with your care or clinical care, whatever you're planning to do. So fit testing, again, another area we talked about a lot. So what is fit testing? So test the seal between the respirator's wearer's face and the respirator. So it takes 15 to 20 minutes to complete, depending upon what kind of testing you are doing. You can do a qualitative fit test or a quantitative fit test. Considering the limitations of the time, I will not be able to go over the difference between those two, but fit testing is important. After passing a fit test with a respirator, you should use the same exact model and the style and the size you use to fit test. A bit about elastomeric respirators, the reusable ones. I'm sure you probably had a lot of questions around, should we go to reusable ones? Yeah, they are a good alternative for current disposable ones, especially when it comes to stock or the different style or the brand. You probably may used to something already, but you probably may not get that. So it is an option, but it requires fit testing. Also, most of these elastomeric respirators comes with exhalation valve. So that prevents us from using it in some of the clinical settings, for example, theater, where you have sterile field. And also if your source or the healthcare worker is already infected with COVID, this exhalation valve will create that positive pressure air coming out and will infect other people around you. So we may need to be very careful with, when you use something with an exhalation valve. Cleaning and disinfection and also maintenance of these elastomeric respirators is quite a challenge. We need to have specific programs and process in place if in case we choose to go that path. Then comes powered air purifying respirators, so we call PAPR. It's a battery-powered blower, provides positive airflow through the filter or a cartridge or a canister to a hood or the face piece to protect the user. Type and amount of airborne contaminant, it dictates the type of the filter you need to use, P2 or a P3. Some parts are reusable and some are single-use. Again, this comes with an exhalation valve, so the same risk of an elastomeric sits with it. And tight fitting PAPR needs fit testing, but loose fitting, there is no need for fit test. So regardless of the type of PPE we use, it's really important for us to don it properly and doff it properly. So following correct sequencing is extremely important. Hand hygiene, I can't say enough. In between, before donning, after you take off, you need to reinforce the PPE. If you have had education previously or you were using PPE forever, still I think refresh is really important, because sometimes, with time restrictions or habit, people can develop, wrong practices or process. So really important to choose the appropriate PPE and properly dispose it, use it safely, especially keeping your hands off your face. Because I think Emil and one of the students did a paper a couple of years ago where they found that we touch our face 21 times normally. So if you have a mask or PPE on, the chances is high. So keep your hands off your face. I think that's one message I really would like to give you. When you don or doff, supervision or body system is important, or at least keeping a mirror next to you, because we just did a bit of fit testing training very recently where people are struggling to get a fit check properly passed because they can't see when they put on a respirator, it's sitting right on their face or not. Supervision, if it is possible, or a body system would be the best, so that they can tell them and help them through to don and doff. Regular auditing is really important. Whatever the process you put in place, if you don't have any governance over, it's not going to work. And also feedback to the staff that are they doing it right or not to criticize, but good feedback will improve compliance and also the confidence in the system. So use of PPE champions or Tiger team being proven to be effective or working. So that's something, if you haven't thought of, definitely try that. So I think these are the main points when you select the respirators or PPE and when you don and doff. I think I'm going to finish there, considerate of the time. Quite over, I think. Handing back over to Angela.
Thank you so much, Susan. Extremely interesting, and we do have lots of questions that are coming in to the Q&A box. Other participants, please keep them coming while these ones get answered. Just in regards, Jane had a question about which is preferred when in close contact with patients, goggles or a shield?
Depend upon the care you're going to provide, and also if you wear prescription glasses, it will be a good idea to use a shield, because it's very hard to put a goggle on top of your prescription glasses. And if you anticipate care for longer period, very close contact, then a face shield is the best. And if you are just going in and just to hand over medication, very brief contact, then you can use a safety glass or a goggle. But if you're okay, and also if your patient's behavioral challenged, if you think that they're going to spit or scream or shout at you, all those kind of situations, you should use a face shield. And also there are a few respirators or masks will not come with a fluid resistance sometimes. And that time, I think a full face shield will be a best option to cover your fluid resistance side of it too.
Rob had a question. If airflow is important for transmission, how much influence does oxygen delivery to a patient have?
Yeah, oxygen delivery, it will depend upon the method you use. If it is just giving through a nasal cannula or a Hudson mask, we don't believe that it's an AGP. So because when we deliver oxygen, we actually giving that as kind of a negative pressure. It's just going inhaled by the patient. And then the exhalation, there's probably will have some droplets coming out, but not in a sense that they normally breathe out, because oxygen is going in, not coming out. So we don't, in New South Wales, we don't consider the oxygen delivery as an AGP. But definitely a surgical mask has been recommended when you go into a patient who, known to be or suspected of having COVID. But for just general oxygen delivery, we don't consider it as an AGP. But if you would like to look at the whole list of AGPs, we have documents published through New South Wales Health. So if you go to Clinical Excellence Commission's website, we have a whole heaps of document and resources available. Can go and have a look at it to see if any of the other procedures you are in bit of a doubt of it's an AGP or not. We haven't covered the whole list. It's very hard to cover every possible procedure. And again, as you know, evidence is still evolving and coming, but we haven't seen any evidence so far which will classify oxygen delivery as a high flow oxygen is different, but the normal oxygen is not.
Mohammed had a question in regards to if they are using an air conditioner that uses fresh air from outside, will it contaminate the outside environment?
I've already answered that one. And
Good.
The group, very briefly, it dissipates so rapidly. And
Beautiful.
also, no research has actually found any live virus in any large amount from air conditioning units.
Excellent.
It's not like Legionella or Legionnaire's disease that lives in the water and then goes through and gets pushed out.
Okay. Karina asks, if we are being precautionary for fomites with all the cleaning, why are we not being precautionary, or one might say even evidence-based now, with airborne level respirator PPE in guidelines?
I think still the debate is there. The evidence is not enough to say it is airborne, but as Emma said, that it depends upon the right condition. So if it is a very small room with a less airflow in very old buildings, and then patient must be COVID positive if we are talking about COVID, that's when the transmission through air or aerosol or that droplet nuclei is being looked at. But all the other time, it comes out as heavy droplets, so surgical mask is enough. Using, as I mentioned in my talk, that respirator is not going to be the answer for every possible issue, because if you are wearing a respirator, you need to get that fitted on your face, you need to do the fit check, especially with the disposable ones. When you move around, talk, run around, as nurses, most audience are, you know how busy your day will be with a patient, speaking to them, doing stuff. So keeping that seal tight on your face and expecting that 94 or 95% leak proof is a challenge. And then the chance of people getting pressure injuries on their face, constantly touching their face, again poses at risk. Then that when the fomite plays a big part, because your hands can get contaminated, and especially when you wear gloves, easily go to your face and touch and contaminate. So having the respirator alone is not going to be giving you the full protection. All the other aspect of good cleaning, hand hygiene, not touching the surfaces and then going back to your face, not handling the mask once you already put it on and then started breathing through, and then getting that seal check every time you do. All this will play a big part when it comes to PPE and the protection you're going to get from it. Would you like to add anything else, Emil?
It's certainly different across the different UN members. So America gives respirator masks to all their healthcare workers, regardless. So they believe that it's on a precautionary basis, not necessarily based on epidemiology or they've got such a huge patient load that they use P2. At the moment, the evidence doesn't support it at WHO that P2s or N95 are necessary for every routine non-aerosol generating patient care. And I think that's reasonable. Louise has asked an very interesting question about how long should a P2 mask be worn for. So I'm going to ask Susan to answer this, and then I'll give you some experience from SARS in 2003.
P2N95, the manufacturer's recommendation mostly that you can wear it up until 8 hours if you can tolerate. But as you know, as a healthcare worker, who is going to wear a respirator on their face without break for 8 hours? That's against the work health and safety legislation. You must eat and drink in between. So normally we would say you can keep it for 4 hours. Surgical mask the same, but that will depend upon what kind of care you provide. If being splashed or sprayed, if you touch frequently, if you think that your respirator got contaminated in any shape or form, or if you need to drink a sip of water, all those kind of times, you will take it down. And if it is disposable, you dispose it off and put a fresh one on back. Or if it is reusable, you will clean them in between. Reusable will again will depend upon what type of respirator you're using. We can't apply the same rules to each and every respirator. But if you ask me the hours, it can go up to 8 hours if you want to keep that on. Over to you, Emil.
When I reviewed the SARS outbreak in a SARS designated hospital where 63 healthcare workers acquired SARS, I identified that there were two opportunities, distinct opportunities where healthcare workers in two different groups over that outbreak acquired SARS. And one was when they rushed in to save patients and didn't put a respirator or a surgical mask on as they were intubating the patient. And then the next one was, I believe, PPE fatigue, because they couldn't wear a mask in between, taking it off and putting it back on. They were frightened of actually running out of supply. So looking at the data, I made the assumption, based on the data alone, that 4 hours was probably the max that healthcare workers can cope with wearing a respirator before they start touching their face. And WHO and the New South Wales Health and Australian Health do suggest that you can extend the use of a mask across patients in a ward, but using it all day for 8 hours is, I think, unwise due to behavior. That would mean you'd have to take it off and put it in a bag and reuse it, because we often need to go to the bathroom and have a break. So 4 hours, I think, is the maximum. What do you think, Susan?
Yeah, I totally agree with you, Emil. Yes, extended use has been recommended, but if you need to drink a sip of water or take a break, and also considering we're seeing more and more pressure injuries due to respirator use or surgical mask use, because some of the mask has this nose bridge quite harsh on face or the skin. So we don't want people to completely erecting their skin or their nose or the cheeks. So every now and then take a break, PPE free, so that your skin get a bit of a airing and bit of a rest. So it's otherwise, if you are in a theater where you are in the middle of a surgery, yes, you can continue wearing it. But on a ward situation where you can take break, we strongly recommend you to take a break because as like hands, you need to have good skin to work clinically.
Jin is asking, which is probably quite pertinent, is the effectiveness of washable masks available in the market now scientifically proven?
We haven't included that in our review of the evidence yet. It hasn't come to WHO to actually ensure that the evidence is perfect. And I certainly haven't looked at any of the evidence. Susan, have you?
No, with cloth mask, yes, definitely gives source control. Like if you have symptoms and if you wear it to protect others from your droplets while you're speaking, talking, sneezing, coughing. But because it's not, the cloth mask doesn't have any fluid resistant layer, if someone cough or sneeze onto you, the particle probably can penetrate, but something is better than nothing. We're not saying that it's not going to be effective. There is definitely a role of, mask to provide you with some form of protection. But again, it's not been validated to definitely say that cloth mask is the way to go. But in non-healthcare settings like public, definitely using, barrier between your microbes to others is a good way to manage, and it will definitely give some form of protection.
Yeah, can I just add to that? Sorry, I thought the question was around healthcare per se, and certainly WHO doesn't support fabric masks for healthcare settings, but definitely in the public, yes. And if you hand wash your 3-layered mask with a polyester and a polypropylene and in a layer, then and you do it very gently so you don't ruin the polypropylene, then absolutely reuse them again, because it's all about the majority of people wearing a mask and the filtering, but certainly it's not good enough in high levels in hospitals. And WHO is now looking at, apparently France is thinking about setting a standard for fabric masks, which I think is a fabulous idea. So because now, you know, there are standards, Australian and New Zealand standards for masks, for their filtration efficacy. And so watch this space. There will be one for fabric masks, but in the community, absolutely get a 3-layered mask, wash it, be gentle, and rewear it again.
So just before we close, I'd like to really thank the audience that has dialed in today. Thank you so much. It's been great. You've been really reactive and interactive, which is wonderful. I'm just going to remind you to complete those evaluation forms, and just a big reminder that next Wednesday, the 14th of October, is the next webinar in the COVID-19 series. And the title of that webinar is Treatment of COVID-19, What Works and What Does Not Work. And that is at 6:30 Australian Eastern Daylight Savings Time. There'll be information on the Immunisation Coalition website, and of course, registration is free. So I would just like to thank everybody for participating. Thank you so much, Mary Louise and Susan. Exceptionally great talks, and thank you very much to everybody that's been involved in this webinar, Prax Hub and Immunisation Coalition. Absolutely wonderful. Thank you very, very much, and enjoy the rest of your evening.